Thank you very much, dear all. First of all, again, I will echo the same message. Big congratulations to the organizing team, Professor Salim Abdesalim, Professor Leila Abed, and all the organizing committee for this fantastic and ever-growing Congress. And many thanks to Professor Firas for the great and kind introduction, and Professor Mabazza, and all the fantastic panel. So in this presentation, I feel I have a huge responsibility. I'm not sure I will be able to deliver the responsibility, but I will try to show you some pitfalls that how echocardiography could be helpful in evaluating patients with acute heart failure. And my main message in this presentation is to be careful when we interpret echocardiography and ultrasound in these patients. I have no disclosures that relates to this presentation, and acute heart failure as defined in the latest guidelines, the ESC, and also the NICE guidance, that it refers to rapid or gradual onset of symptoms of acute heart failure that is severe enough for having the patient seeking urgent medical attention requiring hospital admission. And unfortunately, it remains the leading cause of hospitalization in patients more than 65 years old. And it's still associated with high morbidity and mortality burden. The guidelines from ESC had delivered different algorithms and workups to guide the assessment of these patients, assessing the two main aspects of heart failure management, perfusion and congestion, and also assessing right heart failure, which is an important component of acute heart failure, and also assessing the severe end of the spectrum, which is cardiogenic shock. And in this diagnostic workup from the ESC of new onset acute heart failure, you see that echocardiography and recently lung ultrasound has been introduced as an important parameter in evaluating these patients. And this is at the point of care, at the bedside, which will be followed later by comprehensive echocardiography afterwards. So starting with perfusion, which is one of the two big elements in evaluating patients with acute heart failure, ejection fraction is one of our main standard parameters in evaluating patients with acute heart failure until a point where patient becoming hemodynamically unstable. Then ejection fraction unfortunately becomes invalid because it has many limitations. It is not validated in hemodynamically unstable patients, in shock patients, and it relies on many variables in acutely unstable situations, in preload, afterload, heart rate, and geometric assumptions. And these two examples here on your left-hand side, you have a patient with good ejection fraction and in profound cardiogenic shock. And obviously, this is because the patient had acute severe mitral regurgitation due to rupture mitral leaflet cord, so the blood is going retrogradely in the wrong direction. On your right-hand side, you see a patient, very familiar to all of us, with impaired ejection fraction and very stable hemodynamics. So ejection fraction in acutely unstable patients with acute pulmonary edema and shock is not the answer to assess perfusion. Instead, we should go into evaluating the velocity time integral of the LVOT. And when we do the LVOT assessment, again, we should not do it blindly because we have several limitations for the parameter. We should not blindly follow the number because what could seem as a normal number will be abnormal in certain clinical contexts. For example, VTI of 20, which is apparently a normal number, is abnormal in a patient with sepsis. And also the same, VTI of 20 is abnormal in someone with significant aortic regurgitation. And we should also put in the context, when we evaluate the VTI, the size of the LVOT area, because patients who have dilated or large LVOT area can compensate for a smaller or lower LVOT VTI to maintain the same stroke volume. And also stroke volume assessment by VTI does not tell us which chamber limiting cardiac output, because cardiac output could be limited from the left heart or the right heart or both. And LVOT VTI will be reduced in left or right or biventricular failure. And when we try to go back into physiology and look into the cardiac time intervals, this is a parameter which could be helpful in these situations to tell you which chamber is limiting cardiac output. And that is the total isovolumetric time. And this is the time in which the heart neither fills nor ejects. And actually, this is the wasted time of cardiac cycle. And this is one of the seminal papers which discussed and studied the TIVT by Professor Derek Gibson, the father of physiological echo in the UK. almost about 20 years ago, looking at TIVT in patients with dilated cardiomyopathy and correlating that with the limitation of cardiac output during the butamine stress testing. And they found that TIVT had a strong inverse relationship with stroke volume in these patients and was the major determinant of cardiac output. And you can use the TIVT to evaluate and optimize cardiac output at the bedside by optimizing the AV interval, by epicardial pacing optimization, and also optimizing heart rate. And the second parameter in evaluating acute heart failure and shock is congestion. And we all assess congestion by evaluating left-sided filling pressures, and we all routinely probably perform the E over E prime, but I thought I would bring you the limitations of the E over E prime. Because again, we should not use it blindly because it has many limitations. We should not blindly rely on the ratio because you can have a patient like this patient with a normal E over E prime ratio of 11.8, or actually it's in the intermediate range. And this patient, if you look at the images on the screen, has evidence of significant elevation of left-sided filling pressures. At the top left, you see a short deceleration time, you see an absence of atrial filling and atrial contraction despite the patient being in sinus rhythm because the atrial filling is suppressed. You also see evidence of absence of antegrade filling in the pulmonary vein during systole and prolongation of the retrograde filling during atrial contraction, and also you see diastolic mitral regurgitation. So you have several echocardiographic clues to very high LV-EDP, even you have apparently normal E over E prime ratio. And this is a patient, again, another example of how echo can help us and can mislead us. 45-year-old, suspected ARDS, 10 years after mitral valve replacement for rupture cord, and came with apparently bedside echo performed by one of the juniors, and he said there is no mitral regurgitation seen, although the patient was hypoxic. So we also saw on the echo dilated LV, and we suspected high LV-EDP based on the dilated LV, and also based on the reversal of the paradoxical septal motion, which was expected in this patient who has left bundle branch block. And when TOE was performed, it was confirmed that this patient has significant paravalvular leak, which was the cause of the patient's acute decompensation. And this is another patient, 25 years old, short of breath after flu, worsening organ perfusion. You can see a bit of mitral regurgitation, dilated, impaired left ventricle, low perfusion, low VTI, and also transmitral filling showed suppression of the early passive filling of the left ventricle and isolated dependence on the atrial kick. And this is another sign of significant dyssynchrony and significant elevation of LV-EDP, which was confirmed by color M mode showing diastolic mitral regurgitation. And this patient was super urgently listed for transplantation, required an impella, and then came the role of lung ultrasound to evaluate interstitial pulmonary congestion. You can see here on the right side, B lines, coalescent vertical lines, which indicates congestion. And it's important when we evaluate the lungs that we also think of the heart-lung interactions. Once the patient requires mechanical ventilation, the positive pressure ventilation will significantly affect right ventricular afterload and probably reduce right ventricular stroke volume, which can cause significant hemodynamic compromise, reaching up to cor pulmonale, as you can see in this patient. 72 years old, pneumonia, and PEEP was increased only from 8 to 12, and you can see the significant dilatation of the RV and acute cor pulmonale and reduction of perfusion and LVOT-VTI correlating with that. And you can also use echo to evaluate the coupling between the RV and the pulmonary artery by estimating the TAPSE and the PA systolic pressure, which normally should be more than 0.31, and in this patient it was almost 0.2, which is significantly reduced and indicates uncoupling of the RVPA, and also the RV looking at signs of RV diastolic impairment, which could be found in patients with restrictive right ventricular physiology, and this can be a cause of acute decompensation in critically ill patients. And one of the echocardiographic clues here is finding antegrade flow across the pulmonary artery during atrial contraction. And this is what is defined as the pre-systolic A wave, the one you are seeing here with the white arrow. And when you see this, with shortening of the acceleration time, this is an indication of significant elevation of right ventricular end diastolic pressure. So I will move forward for the sake of time, and I will finish by lung ultrasound. Lung ultrasound is an important add-on to echocardiographic assessment of patients with acute heart failure and shock. Not only because it can detect interstitial edema, but it can also give us prognostic information, and it can give us information about outcome, and it can also add ability to enhance the assessment by echocardiography at the bedside in various acute situations, in cardiogenic shock and also in other types of shock. And we recently published this latest EACVI guidelines on the use of lung ultrasound in heart failure, including chronic and acute heart failure. And finally, my take-home message that echo assessment in acute heart failure is complex. We should not blindly rely on any single parameter. We should be very critical, look with the eye of a physiological echo detective for any pitfall, and put all the parameters together. Never forget the heart-lung interactions, that they are key player in heart failure assessment by echo, and also remember that lung ultrasound can be very useful in this context. And I would like to invite you to tomorrow's workshop for using lung ultrasound in heart failure patients. And finally, integrate echo within the clinical context. Never rely on any echo parameter without putting that within clinical, biomarker, and other imaging data. And thank you very much for your attention.